Hi everyone, welcome to our video. Today we're going to demonstrate on how to use a goniometer and a measuring tape on clinical measurements.
But before we continue, what is goniometer? So, goniometer is a clinical tool used to measure the range of motion of joints in the human body. It helps physiotherapists, occupational therapists, and exercise physiologists like us, as well as clinicians. It is used to quantify joint flexibility, monitor progress during rehabilitation, detect joint stiffness, limitation, or hypermobility, and last, document pre- and post-intervention outcomes. So, what about the measuring tape? Can we just use a normal one? In clinical assessments, it is important to use a non-stretchable and flexible measuring tape. It is commonly used to measure body segment lengths for detecting asymmetries, monitoring growth or muscle development, and identifying potential biomechanical issues that could affect posture or movement. The tape's flexibility allows it to contour to the body smoothly, while still maintaining precision. That's why, for this assessment, we don't use hard or rigid measuring tapes.
Today we're going to demonstrate 4 assessments. So the goniometer, we're going to demonstrate the wrist pronation and also the hip medial rotation. And as for the measuring tape, we're going to measure the upper arm length and also the leg length discrepancy.
Let's begin with the first movement, which is wrist pronation. Wrist pronation is the inward rotation of the forearm that turns the palm downward. This movement happens as the radius crosses over the ulna, mainly at the proximal and distal radio-ulnar joints. Two muscles, the pronator teres and pronator quadratus, work together to pull the radius over the ulna. To reverse this motion, the supinator muscle rotates the forearm back into a palm-up position. Now, let's go through how to measure wrist pronation.
First, position the patient comfortably in a seated position. Ask them to bend their elbow and bring the arm to a supported surface, like a table or the edge of a bed. Make sure the wrist is positioned so it can move freely without restriction. Next, ask the patient to hold a pen or pencil vertically in their hand. This helps provide a clear visual reference during forearm movement. Begin by locating the boning landmark known as the ulnar styloid processes. Once identified, place the goniometer with the flat arm directly over the lateral aspect of the ulnar styloid. Instruct the patient to slowly rotate their forearm inward into pronation. Make sure the shoulder and elbow remain stable. The palm should tend to face downward. Once the patient reaches the end of their range, read the measurement where the moving arm has shifted. Finally, document the angle measured, which side was tested, and note any pain or movement restriction during the assessment.
After measuring, we found the wrist pronation range to be 82 degrees. According to the U.S. Veterans Benefit Administration's Joint Examination Criteria and the Washington State Department of Social and Health Services Range of Motion Evaluation Chart, a wrist pronation measurement of 82 degrees is considered within the normal range of motion. For safety precautions, ensure the elbow is flexed to 90 degrees and supported to isolate the forearm. Instruct the patient to move slowly to avoid discomfort or joint strain. Avoid excessive force, especially in post-injury or post-surgical cases. Move on to the second movement, which is internal hip rotation. Seated internal hip rotation is a movement where the thigh bone or femur rotates inward within the hip joint. While seated with the hips and knees at 90 degrees, this motion causes the lower leg to move outward, away from the body's midline. The primary muscles responsible for internal rotation include the tensor fascia latae, the gluteus minimus, and the anterior fibers of the gluteus medius. These muscles work together to rotate the femur inward and help maintain stability during activities like walking, squatting, or pivoting. The movement occurs at the hip, not the knee, and is commonly assessed to evaluate hip joint mobility and muscular function. Before starting the hip internal rotation measurement, politely ask the patient to remove their shoes and socks to ensure a clear view of the foot and proper alignment of the lower leg. If the patient is wearing long pants, politely request them to raise or roll up the pant leg above the knee to expose the bony landmarks. Next, position the patient seated at the edge of the bed with both hips and knees flexed to 90 degrees. Ensure the patient maintains an upright posture with a neutral pelvis, and make sure the hip can move freely without any restriction. To help locate the anterior patella accurately, especially during seated hip rotation assessments, you can use a visual alignment technique. Start by identifying the medial malleolus, the bony prominence on the inner side of the ankle. From there, hold the goniometer vertically and align it straight upward toward the knee. The point where this vertical line intersect the front of the knee is typically the anterior midpoint of the patella. This technique offers a reliable visual cue for placing the goniometer's fulcrum, especially when the patella isn't easily palpable. The stationary arm should be aligned vertically, while the moving arm follows the tibial crest. Now ask the patient to slowly rotate their lower leg outward so the foot moves away from the midline, producing internal rotation at the hip. Once they reach their end range, read the goniometer. Normal internal rotation typically range from 0 to 45 degrees. Finally, record the result and note any discomfort, restriction, or compensation observed during the test. The measurement of the internal hip rotation is 44 degrees. According to clinical guidelines from U.S. Veterans Benefits Administration's Joint Examination Criteria, the Family Practice Notebook, and the range of motion chart from Physiopedia, hip internal rotation is considered normal within a range of approximately 30 to 45 degrees. With a measured result of 44 degrees, this falls well within the accepted normal range, indicating that the hip joint has healthy mobility without significant restriction. For safety precautions, make sure the hip is in neutral alignment and the femur is parallel to the floor. Ensure pelvic stability and prevent the patient from leaning or rotating the trunk. Use a gentle instruction. Avoid forcing the range, especially if there is known joint pathology. Now, moving into the measuring tape, we're gonna begin with measuring the upper arm length. The upper arm, also known as the brachium, is the region between the shoulder and the elbow. It contains one major bone, the humerus, which extends from the acromion process of the scapula down to the lateral epicondyle near the elbow. Surrounding this bone are key muscles like the bicep brachii at the front and the triceps brachii at the back, which are responsible for elbow flexion and extension. Now that we understand the key structures of the upper arm, let's move on to how we perform the measurement.
Position the patient either standing or seated upright, with their arm relaxed neutrally by their sides. Politely ask for permission to palpate the shoulder and elbow and if necessary, request the patient to roll up their sleeve to expose the area. Next, locate and mark two important bony landmarks using a pin. The lateral border of the acromial process and the shoulder, and the lateral epicondyle of the humerus near the elbow. Then, place the measuring tape vertically along the side of the upper arm and measure the straight line distance between these 2 points. This measurement reflects the upper arm length and is useful for assessing limb symmetry, monitoring growth, or tracking changes during rehabilitation.
For safety precautions, ensure accurate identification and marking of anatomical landmarks. Use a non-stretchable tape and maintain a straight vertical line. Avoid pressing too hard with the tape, especially if there is post-surgical sensitivity. Lastly, we're gonna measure the leg length discrepancy. Leg length discrepancy is a difference in the length of the lower limbs, which can affect posture, walking, and muscle balance. It may lead to issues like back pain or hip strain. Muscles such as the quadratus lumborum, glutes, and hamstrings often compensate for the imbalance. Measuring from the axis to the medial malleolus help identify whether the discrepancy is structural or functional, guiding proper treatment or rehabilitation.
To assess leg length discrepancy, begin by asking the patient to lie flat in a supine position on a firm surface, with both legs fully extended and the pelvis in a neutral position. Before proceeding, ask the patient for permission to palpate bony landmarks, as this involves physical contact. Once permission is granted, gently locate the anterior superior iliac spine, also known as ACIS, on both sides of the pelvis, followed by the medial malleolus, which is a bony bump on the inner side of the ankle. Before using the measuring tape, use a marker pen to mark the exact location of the ACIS and the medial malleolus on each side. This ensures consistent placement of the tape and improves the measurement accuracy. Then, use a non-stretchable measuring tape. Measure the straight line distance from the ACIS to the medial malleolus on the same side. Repeat the process on the opposite leg, ensuring the tape is properly aligned and not twisted. After obtaining both measurements, compare the values. A difference greater than 1 cm may indicate a leg length discrepancy. Record the finding and note any associated symptoms or observable asymmetries.
For safety precautions, patient must be in supine position with neutral pelvis and fully extended legs. Clearly identify and mark the ACIS and medial malleolus before measuring. Ensure tape is straight and patient does not shift position during the measurement. For both upper arm and leg length measurements, symmetry is key. The right and left sides should closely match. For the upper arm, a difference of less than 1 cm is generally considered normal. For leg length, a difference of under 1 cm is also normal, but anything above 2 cm may be clinically significant and could affect posture or walking mechanics. Okay, so that's all for today's demonstration. We covered 2 tools, goniometer for joint range of motion and measuring tape for linear assessment. Don't forget that these techniques are important in clinical and rehab settings to track patients' progress.
Thank you for watching. Don't forget to practice your measurement skills.
Yeah, so don't forget to like, share, and subscribe this video. See you next time. Bye-bye!